Welcome everybody. So we just got done with papilloscamus disorder part 1 and 2. I know it was a pretty extensive one, but I hope you like it. That is the first thing, and you were able to summarize everything right at the very end. So today we are going to start with a fresh topic, that is the bacterial skin infections. Alright, so how are we going to start with it? First of all, we'll have a classification, and then forward we'll go with the topic. Alright, so let us start the topic. So bacterial skin infection. So first of all, I just want your attention right up to this one word, that is pyoderma. Okay, so everywhere you see this one word pyoderma, that is just it's almost equal to like as a bacterial infection. Okay, so pyoderma means bacterial infection. That is simple as. Okay, so as we go forward with this classification, as you can see in the first half we have the non-follicular one and follicular one. As the name suggests, it just means the same, that over here there is no follicle involved and over here there are follicles involved, like the infection is in the follicle. Alright, and we go forward with the classification. We have localized and diffused. Localized means just at one spot, diffuse means the margins are not very clear. Okay, and on the other side, the follicular side, we have folliculitis, infection in the hair, right, and the perifolliculitis around it as well, which involves the hair as well. Okay, so coming on to the very bottom one, the localized superficial one, right? So localized superficial one. So the first one we will be discussing. So all these are individual topics that we're going to learn as we go ahead in this lecture. Okay, so the first one is bullous impetigo. So impetigo, bullous and non-bullous, we're going to learn both of them. Okay, but over here, as far as our classification is concerned, and for the non-follicular localized deep one, we have 𝗖𝗵. All right, 𝗖𝗵. Okay, and for the diffuse superficial, so these two are very commonly seen in our OPD, right? So if we just say that we find, there is some, for example, there is some infection in the skin, okay, but we cannot see like any pus oozing out or something initial stages, but we just see like a very red area which is inflamed, and we have rubor there. So what could be the two differential diagnoses that we have in our head? So these are the two ones. Okay, so if it is superficial, it is erysipelas. Okay, so we learn about them more as we go ahead in our discussion. Erysipelas. If the infection is deep, we would call it cellulitis. Okay, so I'll just tell you that right away what is the main difference between both of these findings. That is, erysipelas is very well defined, and cellulitis, it is not. It is a very diffuse thing. It is not well defined. As we go ahead, we have images to differentiate both of these as well, but I just want to sensitize you with the same right here. Going on to the next part, that is the follicular variant, right? So we have folliculitis and perifolliculitis right here, and over here we have a superficial one and a deep one. Okay, and these are there ahead, right, but these are the main headings. But for the perifolliculitis one, so these are the important parts, right? So the two parts, that is over here, the diffuse one and the perifolliculitis. Yes, so these two are the important ones in this chapter. Others are also important, but as far as the clinical practice goes and the exam goes, so these two are very hot ones. Okay, so we go for the perifolliculitis one. So probably if you might have come across any of the maybe we had this in our lifetime, some or the other, maybe we must have seen, right, these two conditions, that is furuncle and carbuncle. Okay, furuncle and it just means that infection in one hair and infection in a group of hair at one spot. Okay, everything is there ahead. Okay, so we just got done with the main classification, right? So in my lectures, I always focus on classifications, because I feel that we should exactly know what we are learning. I guess I know this is a very basic thing, right? So because the topics are so much in so many different subjects, I personally feel somewhere we forget, like, where was this bacteria from? Was it positive? Was it negative? Was the exact classification of it? So if we know the classification, we are more confident to answer the questions. Right? Okay, fine. Erysipelas, is it follicular? Is it non-follicular? Right? So if we just remember this one thing, concepts are very clear. Right, so some of the more topics that we would cover in this chapter are these. First of all, we have anthrax, Pseudomonas infection, ecthyma granulosa, and toxin mediated, that is Streptococcus and Staphylococcus, right? So these two will be there. So SSSS, yes, and the endotoxins which these two organisms make, they cause mayhem in the body of probably any pediatric patients or any adult individual, right? So Staphylococcal Scalded Skin Syndrome, yes, so that is the condition we would be discussing in the lecture ahead. The next one is the Corynebacterial infection. 3 topics: erythema, petit keratolysis, and trichomycosis axillaris. So these are waiting for us down the chapter. Okay, so I hope I gave you a very good brief overview about it, right? So we can just begin with the topic. But first of all, I want to ask you one question with the anthrax. Yes. So I know we are discussing my derma, but these all the subjects are interconnected, right? So I'm very sure that when you did your microbiology, right, you might have come across this one topic, anthrax, and there are 2 types of anthrax. So could you please tell me which 2 types of anthrax are there? Yes. So first of all, over here, because it's a derma, we only want to discuss the derma part. Yes, but I want to touch the micro part as well, because I want to get that interlinking in your head, those bridges I want to form. Right, so first of all, it is a cutaneous anthrax, right? That is we are discussing today, we will be discussing. And the next one is a pulmonary anthrax, right? So cutaneous anthrax, one more question right here for you guys. What occupation predisposes of having a cutaneous anthrax? So what is it? Yes, tell me. I'm giving you 3 seconds. 1, 2, 3. Okay, so hide porters, right? So the people who are working in the leather industries, yes, they are the ones who are predisposed to having anthrax, the cutaneous anthrax. Okay, alright, so I hope if you have seen this thing, well and good. If not, it does not matter, right? We will be discussing everything in our head, in the chapter ahead. Okay, alright, fine. Let us begin with the first one, that is the non-bullous impetigo, right? Also known as Impetigo contagiosa. Why? It is very infectious, right? Yes, the vesicles, when they burst, they're very infectious. Okay, why non-bullous? Because obviously the lesions, right, they ooze out and they form a crust. Yes, when we see the presentation in the patient, we'll define a word, right, for it, which is a very classical word for this specific disease. Okay, fine. So who causes it? Staph and strep, or combined. So either of these, or they are combined, they can cause it. Face is the most common site, specifically the perioral area. It is very common, right? Right here you can see in the image as well. Okay, right, and this point is pretty important. Yes, so in the developed countries and the developing countries, yes, so first of all, we should read our questions properly, what we are asked. Yes, so if developed is mentioned, so Staphylococcus is the one who is responsible for it. If it is developing, it is Streptococcus. Alright, so these 2 organisms, so just because like in a question, right, both of these are mentioned, and they mention, like, a name of a developed country and name of developing country, so our answers would change. That is the reason. Okay, so this is the most like hot words in this topic, that is the flaccid blisters when they rupture, right? When they rupture, so that is where the whole story changes. Yes, what do we find there is they become golden colored, right? They become golden colored. Okay, but what is the very hot word here? It is honey colored. Honey colored crust. Okay, all right, so that is one thing. And yeah, talking about the complications of this specific disease, right? So I know there are only 2 organisms causing it, right? So Staphylococcus and Streptococcus. So if this happens in a pediatric patient, right, so there is one very famous we read in our nephro, right? So what is it? So complications is post-streptococcal glomerulonephritis. Yes. And what is the treatment for it? Treatment, we would just be going forward with just the antibiotics, right? But if it's specifically if it is PSGN, right? So yeah, definitely we'll be giving the antibiotics, and we'll add steroids as well, right, to control the nephritic symptoms. Okay, all right. So let us just fill in our notes. So the complications would be PSGN. So post streptococcal glomerulonephritis. All right, that is one complications for this. Okay, all right. So how do we go about the treatment options? Yes, we can apply topical mupirocin and fusidic acid. Yes, and orally we can give dicloxacillin, amoxicillin plus clavulanic acid, right? So we are giving antibiotics to treat the causative organism. That's it, simple. Yes, so let us go ahead and just see the images for this, right? So over here we have this golden color crust which is formed by the breakage of the flaccid blisters, right? So that is the whole the reason of these guys forming in. Yes, so non-bullous impetigo. All right, non-bullous impetigo. How about these are the impetigo, this is the non-bullous form, these are the bullous form, right? If you can see here, these are the bullous form. We can see quite an amount of bulla over here, and over here you can see like there were these flaccid blisters, but they bursted out. Yes. Okay, so just these two things we discussed, and now we go on to the next one, that is the bullous impetigo, right? The counterpart of this, that is the bullous impetigo, right? So pemphigus neonatorum is, we also call this pemphigus neonatorum. All right, so let's just come to the image in the first place. So definitely you can see there's a lot of fluid that has been oozing out. Yes, so probably if there was an image which was taken before happening of this, we could have seen the bulla properly, right? So but this image does the job fairly well. Okay, all right. So over here we have a little bit of concept, right? So if it is a local infection, so it's going to cause bullous impetigo. Okay, if this same thing, yes, happens systemically, we would have Staphylococcal Scalded Skin Syndrome. Okay, SSSS. So this is very hot topic as far as microbiology is concerned or dermatology is concerned, right? Because this Staph aureus is a very famous organism causing everything. We read about this one organism in so many places, so this becomes very important, right? So, and also Aureus means gold, right? Staph aureus means gold. Gold is just like honey colored crust which is being formed. Okay, so we can have those correlations as we go ahead. Okay, Staph aureus. So what this guy does is, right, so it causes a big mayhem. How does it do it? It makes this epidermolytic toxin. Okay, and so this toxin, what it does is then it comes and destroys the DSG1, that is the desmoglein 1, alright, which causes the cells which causes the acantholysis, and the acantholytic cells are formed, right? That is the reason we have the whole bulla formation. Okay, now I just gave you a little bit overview about how this epidermolytic toxin works, but ahead we have a full diagram representing this as well. So over here I just want you to focus on two things, right? So first is the DSG1, yes, and right here that this is a toxin mediated bulla, right? And it is not an autoimmune mediated one. Okay, so why did I write this here is because two reasons, right? So if we see a bulla, oh okay, fine, I know it, right? I know bullous impetigo. I definitely know, sir taught me that yes, there is DSG1 is happening and there is bulla formation, but this is because of a bacteria. It is not because of antibodies, right? So we have to keep this point very clear that even though the desmogleins are involved, it is not because of antibodies, it is because of bacteria. Okay, that is another reason that this topic becomes very hot. Why? Because the presentation is the same but the etiology is different, and only the one who knows a specific etiology properly to its point, like pinpoint thing, we have that confidence in ourselves that okay fine, yes, I know it, I know the exact reason why my patient is suffering from this, and if we know it well, we can treat well, right? And we can become good clinicians down the line. Alright, so let us come to the topic. That is, this is not an autoimmune mediated. This is because of the bacteria, right? That is the epidermolytic toxin. Okay, epidermolytic toxin. Okay, fine. So we're done with this point. So let us just focus on this for a moment. Okay, so how would you define this? Yes sir, I do see a bulla. Yes sir, I do see pus inside it. Okay, fine, correct, absolutely right. How would you define this to me? Is there any specific way? I hope maybe you have done your ophthalmology, maybe you have not done your ophthalmology, right? So the word over here we use is hypopyon. Alright, so when do we use the word hypopyon, right? So whenever the pus settles at the base, we say it as a hypopyon. Okay, fine, okay, cool, we got it. We have a new vocabulary in our list, that is hypopyon. Okay, so how about we could like discuss the word hypopyon related to dermatology and ophthalmology as well. Okay, so let us just take this opportunity. So I get to teach ophtha as well. So okay, fine. So we are reading about hypopyon. Okay, all right. The only reason whenever I read, right, so I just try to get everything at one spot. So wherever I read hypopyon, wherever I read like anything, everything should come in my mind, right? So there should be those interlinking things. Whenever I read, I always make sure that I do this. That is what I'm doing here and teaching you guys. Alright, so hypopyon. Where do we read this? Is in the fungal and bacterial infections. Alright, fungal and bacterial corneal infections. Okay, so fungal infection, fungal and bacterial infections. Okay, alright, so the hypopyon is seen in both of these. Okay, hypopyon is seen in both of this, right? So we have this hypopyon here. Okay, fine, we have this right here. So but if it is a fungal one or if it is a bacterial one, right? So how would we differentiate in it? First of all, what we would do is, if it is a fungal one, the hypopyon will be fixed. Okay, it would be fixed. And if it is a bacterial one, the hypopyon would be moving. Okay, fine. So for example, so like if any person is having an eye infection, right? For example, there's corneal infection, and if you see it, right? So and if you just tilt the head of the patient, so if the hypopyon moves, just because it moves, we can say it is bacterial, and if it is fixed, we would say it is a fungal infection. Okay, so just by this one point, you can just the treatment is the treatment totally changes, right? So that is a good point about of being a good clinician, right? So we can see things and we can just specifically come to that diagnosis point, right? So as beautiful as this point is, so how would we remember it? Is fungal, fixed, simple, right? So I always remember it like this: fungal fixed, other is moving. So I don't care about the bacterial one, but I know that fungal is fixed. Okay, fine. So we come back to our dermatology, right? So hypopyon, we discuss a few points over here as well. Okay, and if we just do the histopathology of this thing, blisters are below the stratum corneum, right? In the whole thing, stratum corneum, they are below that. Okay, so that is the reason the fluid oozes out and we have the blister formation. Okay, so that is what we will be learning in our next diagram, that is this. Okay, ladies and gentlemen, so let us learn how the blisters are formed. Okay, all right, and why there is oozing of this golden colored, honey colored crust. Why is all this mayhem being happening, right? Is because of this thing. The staphylococcus, it enters the skin. This is the point one, right? So this is the one who is causing the insult of the skin. It enters the skin, right, and it makes this toxin, right? So the ET toxin, epidermolytic toxin, right? This is made by the bacteria, and what it does is it goes and damages the desmosome 1. Yes, the DSG1 is being destroyed, right? So what was one thing that the desmosomes were doing. If you guys just go on to the first chapter that we discussed, right? So we discussed about desmosomes very extensively, and I drew a very beautiful diagram there, right? So just to get that head clear, how do these desmosomes look? Yes, so over here what do we have is that the DSG1, right? Those are being attacked by the epidermolytic toxin. Okay, fine. So what it is doing is it is just holding on to one cell to another, right? One keratinocyte to another keratinocyte it is holding. Yes, so the ED toxin comes and just damages this. Okay, so if this is damaged, right? So there is a specific process that we discussed in a very detailed, elaborative manner, right? That was acantholysis. This is acantholysis, right? Now what happens, these two cells, these are just free floating cells, they are not like adhered to each other. What this happened, like there is some space, right, which was used by these two cells. Now there is free space. Now this free space, there is fluid coming in this space, right, and finally it oozes out, which leads to formation of blisters. Okay, alright, so that is what we have drawn here in this diagram. That is, there is subcorneal acantholysis and fluid collection, it is there, and the last step, that is epidermal blisters are formed. Okay, so I hope this one thing is very clear, right? So why there is formation of blisters in the impetigo? Maybe it is bullous, maybe it is non-bullous, right? At some point there is fluid oozing out, there are some sort of blisters being formed. Could be flaccid, could be like proper bullous one. Okay, so I hope this one thing is very clear to you, right? So I usually want to know the exact pinpoint pathophysiology, so that, because these things, if we learn it once, I'm pretty sure these things are so intuitive that we never forget it, right? I'm pretty sure, like if I go on for like so many hours about talking about something, these are of things like the mechanisms and the actions, like what is actually happening, we don't forget it. It is so, because it is very interesting to learn, right? Yes, so I hope it is interesting to you as well, as much as it is to me to teach you guys. And thank you so much for listening. Yes, so we go on to the next one, that is the diagnosis part. Okay, so the diagnosis part, how would we do it? It's pretty simple, right? So either only two organisms, right? So either it is Staph or Strep. I know we're going to give antibiotics, and the patient is going to be treated. Yes, so we could do a gram stain. We can find somebody in cocci, or it can be a grape-like clusters, right? The Streptococcus would be there if this condition is there. Okay, alright, so we just got done with the superficial one, right? That is the impetigo. Now let us go back to the classification and see where we are right now. Okay, right here. Okay, students, we just got done with this part. Okay, now we are heading to the deep part. The non-follicular localized deep would be our topic, that is 𝗖𝗵. Okay, fine, cool. Let us begin with it. 𝗖𝗵, a pretty short, straightforward topic, but if you know, you know. If you don't know, you don't know. Okay, how would you describe this lesion to me? Right, this or this? How would you describe this lesion to me? Okay, the best minds would say that, okay, fine, I can see some ulceration, right? There is some dimpling there, the skin is dead, it is necrosed skin. At the very periphery, I can see some sort of scaling, right? There is erythema here, there is some scaling in the periphery part, right? And over here there is dead tissue here. Okay, all right, so that is how we would describe it. Yes, but before that, yes, if you see over here, before this image was taken, there would have been crust. Yes, if the crust was removed, if the crust is taken off, right? So this would be the base of that crust, right, which was removed, and it is like a meteor being struck on the hand, right? We have ulceration there, right? We have ulceration there. Okay, all right, fine. So the abuse is by same organism, by Strep or Staph. Yes, Strep or Staph. And how we would describe this is thick adherent crust when removed creates an ulcer. Okay, simple as that. Nothing much complicated with the eczema. Usually it's more common in the lower extremities. Okay, that is all for the eczema part. So okay, so we just got done with one half of it. Right now we have the non-follicular variants. Yes, non-follicular diffuse variant. So we just got done with the localized variant, right? So now we are in the diffuse one. Okay, so I hope you can just have that classification in your mind, right? Okay, so we are in the diffuse one. So these are the two things that I told you that these are important ones as far as the clinical conditions are concerned. All of it is important, but just telling you, as there is infection inside the skin, so these two differential diagnoses should come in our head. Alright, fine. So erysipelas is the one, right? And erysipelas is a superficial one, and cellulitis is a deep one, right? So, and I told you that erysipelas, the margins are very well defined. So well defined margins are there. Okay, erysipelas, well defined margin, and cellulitis, there is diffuse inflammation in it. Okay, who is the one causing it? That is beta hemolytic group A Streptococcus is the one who's causing it. Okay, and the reason that it is very well defined, that is, it just involves the dermal lymphatics. Okay, it does not involve the subcutaneous tissue. The further one, that is the cellulitis, it involves the subcutaneous tissue. That is the reason it presents as a very non-marginized infection. Alright, okay, this is the reason, right? That because the erysipelas only involves the dermal lymphatics. That is the reason we have very well marginized lesions are there. Okay, coming to the next one, that is the cellulitis. Yes, in this yes, it is deep variant of it, right, of the non-follicular. This is the deep variant, right, the deep one. It involves the whole dermis and the subcutaneous tissue, right? So because the involvement is quite large, it is quite extensive, right? That is the reason the presentation, this is what there are the difference between erysipelas and the cellulitis. Okay, alright, so the subcutaneous tissue infections tending to separate, right? So they just get diffused. Okay, and the erythema usually occurs on the face or the legs. So I had one patient of cellulitis, right? So the boy was, I guess, probably 19 years old boy, right? He come to the clinic and he was like, he showed me his leg that, see doctor, this is happening, and it is, my leg is very inflamed, is very red, and it also the temperature is increased of the specific area, right? And if we just touch the area, and if it just compare this affected area and the normal area, right? So this is hot. So I know this is very obvious, right? But we go to the hospital, we see these patients. So these are the signs we should look for. If you see cellulitis, okay, fine. Just go on and write antibiotics and you go home and take the treatment. We see it, right? And these are the manifestations of this specific disease that we have. We get to learn, we get to see it, right? So fine. Okay, so that was there, and we treated that patient with simple, antibiotics, and the patient got treated. But the thing was, this infection, he had it recurrently. He came to me 2 times. Yes, he was having this recurrent infection, but yeah, now he's okay. Now he's absolutely fine. But still, there could be recurrence of this as well. Okay. All right. So that was about cellulitis. Okay. Cellulitis, I hope this one point you can remember, that it is a diffuse one. The involvement is quite extensive. That is the reason we have a lot of areas being involved in it, right? So the margins are not very well defined. Okay, all right, fine. So that was all about it. So let us go on and just see the images right here. Images we see here is so obvious that it is erysipelas. It's so obvious. If you just remember that one point that I taught you, that erysipelas, it is going to be margin. We will have margins, right? So you see, it's so easy. If we know things become easy. If we don't know it, it's always those 4 options, right? A, B, C, D, and just eliminating 2 is the most easiest thing. But even the examiners knows that okay, fine, these would be able to get that 50% thing right. Only 2 of them options are correct. But that is where the examiner plays, that fine, give them such easy options that they get confused. Only if they know one thing, they will be able to come to that point. So this is that point. Okay, all right. So we go on with our lecture. That is, this is erysipelas, and what about this is erysipelas? No, right? So see, almost the whole leg is involved, right? Even though this photo is not taken by me, right? So the doctor who took it doctor or nurse who took this photo, they try to like elicit that okay, fine, till here there is the infection. Yes, okay. And over here as well, the same thing we have, like right here and right here. So this whole area is involved, right? Okay. How about this one? Butterfly rash, huh? SLE, huh? You seeing that? Absolutely not, right? History is important, okay? Don't go ahead and mark things if you see this image. Simply, it could be erysipelas, okay? That is the reason, we should know everything. in the derma, in micro, in the medicine, so that we can come to that one specific answer. Right here we see inflammation well defined, very well defined, erysipelas. Okay, all right, so that is all about the non-follicular diffuse variant. Okay, so the next topic is going to be about the follicular one, right? Okay, so let us just come to the next topic, that is the follicular infections. Okay, so this is pretty short one. Okay, the follicular infections, so over here we either have deep or it is superficial, either it is deep or it is a superficial folliculitis. Okay, if you can just see here, right, let us do this one first. If we just see over here, right, superficial folliculitis, simple, that one hair are being involved, like single hairs are involved in it. Okay, all right, probably whenever, I guess probably all of us at some point in our life faced this, right? Probably we got some, especially while just for say shaving the beard, right? Sometimes guys have this, right, shave a beard, right? So at the next day or at the evening, in case someone shaves in the morning, we have these tiny bumps, right? These are the folliculitis, right? So this is that thing. This definitely didn't happen after a shave or something. This is a very aggressive looking thing, right? Even though it feels like it is like all the hairs are involved, but if you can just see, right, there are individual hair involved, right? And it is not like they are coalescing with each other. The individual ones, just like individual ones, right? Okay, simple as that. So this is still a superficial folliculitis, it is not a deep variant. Okay, all right, so this condition is called as a Bocard's impetigo. Okay, all right, so it is not bullous, non-bullous form, it is Bocard's impetigo. Okay, this specific variant. Okay, all right, fine. So now we know the superficial one, so I guess deep one would be pretty easy. This image you can see over here, right? So I guess everyone will agree that this is not superficial for sure. Yes, for sure this is not superficial. Okay, deep follicular infections. Okay, so we just got done with the follicular variant, right? So the next in our list is perifolliculitis. So I hope now you can get that part on the classification, that 1, 2, 3, and we are in the fourth one. Okay, so okay, fine, let us just go check that as well. Okay, fine, so we got done with this one, this variant, and now we are right here. Okay, we go on to the perifolliculitis. Okay, fine, so over here we have two things. Yes, we wrote over there furuncle and carbuncle. Okay, let us just go and just zoom in this image, right? So first we have the normal hair, we have the furuncle, and we have the carbuncle. Self-explanatory things. Furuncle, only one hair is involved. Carbuncle, yes, one hair is involved, another hair is involved, and they are coalescing with each other, right? So they have an infection like a together unit, right? They're coalescing with each other and forming one unit, one full aggressive looking thing, or as a carbuncle. Okay, let us just fill out our note. That is, first of all, if it is a severe infection, yes, so follicle plus perifollicular area, follicle plus perifollicular area, this is furuncle. Okay, all right, so the other one, it is a carbuncle, right? So let us just see the image. Only one hair is involved. It is over here we have this perifollicular area right here, red erythematous thing, right? But only one hair is involved. Okay, but in contrast with this one, you see a carbuncle. Definitely there are multiple hairs involved in it, and you see there is this diffuse looking thing, right, coalescing with each other. What is this called as? We call it as a carbuncle, right? Okay, all right, fine. So multiple and single. Okay, cool. So let us just go on to the next topic, that is, so now we're done with the whole classification part, everything is done, right? So now we are in the others list, right? That is the first topic I would like to take up is the bacterial toxin mediated syndromes, right? Even though in the list we have anthrax, now I would like to discuss the bacterial toxins. Okay, third time discussing in our lecture, the same lecture, that is SSSS, also we call it as a Ritter's disease. Yes, and over here this very interesting, right? So even though you know how the epidermolytic toxin works right now, yes, what is most important is that, okay, fine, so from somewhere there is this infection, right? There is this source of infection, but what is interesting to know is, Okay, fine, from where is the infection coming? So it could be having that there is a very young pediatric patient, right, and he has something called as otitis media, right, something called as otitis media. Okay, infection in the middle ear, right, otitis media. Okay, all right, that could be one thing. So he has that condition, yes, so and that is the reason that, okay, fine, it is the most common is Staph aureus, right, which causes it. And from over here, probably he is having the systemic involvement of his body, right, and just imagine bacteria is over here, it is making the toxin, that is the epidermolytic toxin, yes, and what's going to happen, yes, just imagine that diagram we just discussed a few minutes back, right? The organism comes in, right, and it is making the epidermolytic toxin that goes ahead and just breaks the desmosome, right? The DSG1 has been broken up, right? That is the reason we'll have the blisters formation, right, and the acantholysis steps will be initiated because of this one thing. Okay, all right, so this point is being explained over here, that is, it could have an otitis media, could have, right, it is not like only this condition will have, there could be n number of causes, right, but the concept is that the bacteria is spreading the toxin in the body. Okay, all right, so it could be an otitis media, it could be a furuncle, right, from where endotoxin spreads endogenously, there is systemic involvement of this toxin. Okay, all right, fine, so you can, as you can see in this child, right, so over here you see, because of this toxin, you can see in the perifollicular area as well as on the cheeks, right, over here you can see, what is happening is the skin, is being getting scuffed off, right, the skin getting scuffed off, it is a sign we discussed before, this is a Nikolsky sign. If we apply a tangential pressure to the blister and it is just slides off, it is a positive Nikolsky sign. Okay, all right, as simple as that. Okay, so perioral scaling which is there, and crust, superficial erosions, and abscess of mucosal involvement. Okay, and the Nikolsky sign is positive as we just discussed. And histopathology, I guess we discussed already, right? This diagram I discuss here is for the Staphylococcal Scalded skin syndrome. Okay, this is the histopathological finding of this specific disease. Okay, so we discussed this one topic 2 times in one lecture, right? So I hope I'm very clear with this. Okay, and you will never make a mistake in this topic. Okay, all right, so we are going on to the next topic. Yes, so we done with the bacterial toxins, and for us we have the Corynebacterial infections waiting for us. Okay, so here we have them 3 guys. Yes, so let us just write them out real quick, even though we in the early part we mentioned these 3 names as already. Okay, so first of all, it is what? Erysipelas? No, right, it is erythrasma. Erythrasma and pitted keratolysis. Third one, it is trichomycosis axillaris. Okay, all right, so these 3 would be the topics of discussions from here on. We are reading about Corynebacterial infections, and we have 3 guys in the hit list, right? So we have erythrasma, pitted keratolysis, and trichomonas axillaris. Okay, so the first one over here is erythrasma. If we see from a naked eye, right, from a naked eye, we would see brown red patches in the intertriginous areas, that is under the armpits, right, and below the folds of the skin, right? So they are the intertriginous areas. Okay, we would see there. And what is the etiology? Yes, the topic we are reading, right, the Corynebacterium ministrum. All right, this is the one who is causing all the mayhem. But if we just put an Wood's light on, right, in the infection, right, so what would we see? Ladies and gentlemen? So I hope this can ring a few bells in your head. Yes, when we were discussing about the introduction in dermatology, we discussed all the investigations as far as the Wood's lamp is concerned, right? So I hope you guys can go ahead and just read that once again, yes, so that you guys have a good memory of. Okay, erythrasma, what color do we see? The color is very important. The examiners are banging their head on this one topic, that is the coral red fluorescence. Okay, let us just write it, coral red. It should be written in red. Coral red. And the reason why do we have this, why is this particular color being imparted to the skin under the light, is because of the porphyrins. Okay, alright, so porphyrins we will be learning extensively in dermatology when we read the topic Porphyria cutanea tarda, okay, PCT. Okay, we will be learning about this one thing, which is a connection to the biochemistry part. Yes, why this happens, why there is deposition of this, and everything regarding it will be discussed in that topic. We also discuss in our rapid revision session as well, but in this detailed series we will be learning about this one topic in very great detail. It is pretty interesting, right? Okay, fine. So over here we can see, right, this coral red fluorescence under the Woods lamp. Okay, the next one we have is pitted keratolysis. Keratolysis, the skin is being lysed. There is no skin in that specific area. Like the pits, we don't have any skin there. Okay, pretty self-explanatory, right? So what obviously, something like this, the predisposition would be what somebody is working in water, in like areas which are very moist, which are very wet. Yes, so sweaty areas and humid, in summer times, this condition could be there. Okay, who's causing it, ladies and gentlemen? Corynebacterium diphtheria, right? Okay, who causes it? It is Micrococcus sedentarius. Okay, this is the one causing it. Not a very famous one, but yes, we should know the etiology of pitted keratolysis, right? Okay, fine. So let me just zoom it in. I guess these sort of images, they float around the internet quite a lot. Yes, so because these are not like very pleasing to the eye, right? We just get that feeling when we see this. Yes, even though as being a doctor, we don't usually have this sort of expressions, when we see these in our patients, but still in our heart and in our mind, we do it, right? Okay, fine. We just got done with one more topic, that is the pitted keratolysis. So this gets on to the next topic, that is Trichomonas axillaris, Trichomycosis axillaris, Trichomycosis axillaris. Alright, so Corynebacterium infection of the hair shaft, of the shaft of the hair. Okay, so we will be learning about the hair part extensively, right? When we do the other infections of the fungal infections, when we do it, the hair part, the dermatophytes, they cause a lot of mayhem in the skin, in the hair and the nail. Right, so we'll be learning extensively over there and in the appendages chapter as well. But for now, let us just focus on the Trichomycosis axillaris. And over here, what we have is colored nodular thickenings will be there, right? So if you can see in this, yes, so we can clearly appreciate, right? So there is this shaft of the hair, that is the middle part of the hair. Right, that is where this organism is there. Okay, misnomer, not caused by fungal infection. We are obviously reading a bacterial infection, right? So it is by bacteria. Okay, all right. Going on to the next one, that is the anthrax. So we read about two things, pulmonary and cutaneous, right? So we are reading about the cutaneous part. Okay, the Hyde Potter's one. Who is causing it? There is a Bacillus anthracis is the one who's causing it. Okay, all right. It is a zoonotic infection. Yes. Why? It has been transferred from animals to human beings, right? Who is transferred? This gentleman is being transferred. Okay. Seen in what? Livestock handlers. Is seen the people from the leather industry, right? Usually have this. The one who is transporting the hide, that is the skin of the animals, right? Okay. The next one is the lesions, right? We name it as malignant pustules, but there is no malignance about it, right? It is 100%, it is a misnomer. This is not a malignancy. Okay, all right. How would we describe this? Is right. Okay, fine. We have central crusting. Yes, we have central crusting in the center and erythema in the periphery. Right, you can see in this one. This is a better image as compared to the first one. Central crusting, yes. Periphery erythema. Yes. Okay, so that was all about bacterial skin infections, right? So a very short chapter, yes, but pretty important as far as exams are concerned and our clinical presentations are concerned, right? So I hope you guys had a good listen to it, and I hope you guys can remember all the informations, and act in a very, this information should be useful for us when we practice clinically. Okay, fine. Thank you so much for listening.